My name is Olivier Mazil. I am in charge of medical affairs for Nanosonics in Europe. So today we will speak about the risks connected to suboptimal reprocessing of ultrasound probes. So I have a big pleasure to welcome our speaker today, Helen Campbell. So the floor is yours, Helen.
Hello, I'm Helen. I've worked in the NHS for over 20 years. I retired at the wrong time, right at the beginning of the pandemic. So, yeah, not a good time to sort of come out and go self-employed and do teaching and that sort of thing. I'm also the Director of Education for the IDSC, so the Institute of Decontamination Science. So that's mainly for people working in endoscopy and in SSD, so reprocessing reusable medical devices. In my role within the NHS, I was decon manager, so I did combined audits with infection prevention, went all around the hospital looking at things, and that's where my interest really in ultrasound probes came in, that we found there were a few problems basically with them. So if everyone's ready, we'll get started. So ultrasound probes are classified as medical devices. So it's important when you get a medical device to follow the manufacturer's instructions. So you're looking at not only the manufacturer's instructions on how to use them as a clinician, but you're also following the manufacturer's instructions on how to clean them, clean and disinfect them. So you need to follow the method of the IFUs, what it states, the contact time, and you need to think about the compatibility of chemicals that you use, not only with the probe, but with the lead and that sort of thing. There's some probes that have been in hospitals for donkey's years. We all know that they sort of come out the woodwork, and there's no IFUs with them. They've been lost. You don't know who the manufacturer is because they've amalgamated with somebody else. So what do you do then? So what you're looking at is you're looking at best practice then. What is the recommendations? What legislation does it come under? So it will come under sort of the Healthcare Act and looking at how that's broken down with the HTMs. So you've got a whole lot of HTMs. 0101 deals with decontamination mainly and gives you the terminology and that sort of thing. And 0106 deals with endoscopy. So you're looking at which one fits better for ultrasound probes. So it's mainly 0106. When you're talking to clinicians about ultrasound probes, they are really keen to get the washing and the cleaning and the disinfection of ultrasound probes correct so that they don't cause infections with patients. So when you're thinking about ultrasound probes, you're looking at some hospitals have got departments that use ultrasound probes a lot, sort of early pregnancy, that sort of thing. You know you will find ultrasound probes there. And they've probably got SOPs, which reflect the IFUs, sorry, it's all acronyms here, that reflect what they're meant to do. So they will have a risk assessment done following the manufacturer's instructions. So the manufacturer, you say you can use these chemicals, these wipes, they will reflect that within their SOPs, usually done in conjunction with infection prevention. So somebody in infection prevention, the lead nurse or one of the nurses or somebody in decon, even the DIPSI, will look at it. And ultimately, it's the decon lead that is responsible within your hospital for ensuring that the cleaning method is correct. So cleaning and disinfection are correct. So if you don't follow the IFUs, you are likely to cause problems with the probes. It might not be immediately obvious what the problems are, but there will be problems. When you're thinking about SOPs, you need to ensure that staff are aware of the SOPs. There's absolutely no point in having them stuffed in an office where the manager knows where they are, but the staff don't. They need to be regularly reviewed, they need to be issued number, dated, the normal things. But quite often within procedure rooms, that doesn't happen. You don't review your SOPs and keep them up to date. sort of within your quality management with either infection prevention or decon, you should have a review process. You know, it might be you review them every year or every 2 years or every 3 years. But really after 3 years, things could be slipping and getting out of date. So you do need to ensure you've got a tight handle on the SOPs, who last reviewed them, when they were reviewed, and where they're kept. And this includes sort of training for your staff that have got the SOPs. So you know that your staff have read the training. If a new member of staff comes in, how do you prove that they've read it? Have they signed it? Have they dated it? Do you know when a revision has been done that all the staff have read that revision? So it's all about record keeping and how long to keep the records. So we've talked about the units that you have where you regularly use ultrasound probes. But you have a lot of units that borrow ultrasound probes. And now working in a hospital, nearly every department has an ultrasound probe. When you're thinking about how do you go about finding all the ultrasound probes in the hospital, there's a toolkit that Nanosonics have developed, and it's actually free. You can download it and you can use it, and it gives you a help of how to identify it. So, for instance, the first toolkit will tell you, go to your estates or your instrument management. They will have an asset register of where everything is. Ultrasound probes tend to be missed off the asset register, I've discovered. Also go to purchasing, find out who's using the gel, because you'll find the ultrasound probes that are missing. But we did audits for 4 years in one hospital that I worked in, and about the last few months that I was working there, a member of my staff went to occupational health and came back and said, I had an ultrasound probe used on my knee. We hadn't been to occupational health. We didn't know they had an ultrasound probe. So it is a question of looking everywhere. But the toolkit does help you to go through a process, and that's what you need to do. So when you're talking about probes that are used elsewhere in the hospital, how do you know they're cleaned? Do they bring them back to your department? They've borrowed one. Do they bring them back clean? Have they recorded it? Are they kept moist? If you keep a probe moist, it's easier to clean. We all know that if you have spaghetti bolognese in the evening and you leave your plate on the side, the next morning it's really difficult to get cleaned. You've got that sort of orange scum on it. Whereas if you rinse it off that night, you can clean it easily. It's exactly that principle. If you keep it moist, it's easier to remove the dirt and the contamination and the protein that's stuck to the probe. You've got to look at, if something's been borrowed, do they use the same gel as you? They might not. They might have a cheaper one. They might have a different one. Are they recording the patient details against that? Do you know who it's been used on if there is a problem? Is what they're using compatible with the probe? Because you've got the instructions. Have you given the instructions to them? Are they aware of it? If it's returned dirty, you want it kept moist. You only want it used on one patient and then you want to clean it. You don't want it repeatedly used before it comes back to you for cleaning. If they're cleaning, are they aware of what needs to be done? Sort of from clean to dirty, are they aware of that? Or do they do from dirty to clean and contaminate your lead, where you're going to handle it to plug it into the machine? Do they have a method of cleaning? Do they have from dirty to clean when they're cleaning? So they're not putting a clean scope in the same area that they put the dirty scope. I've seen people have a dirty probe. It comes in, they have a piece of blue paper down, put the probe on that, clean it, take that blue paper out and put it down on the same place on the counter. So obviously contamination, bugs do not go through that bit of blue paper. That's enough to keep it safe. So are you sure that if you're loaning your scope, they're cleaning it properly? It's not coming back to you contaminated and putting you and your staff at risk. So the questions you need to ask: how do I find and identify ultrasound probes? You will know what you do in your department. But as I say, if they're borrowed to one department. Are they lending them out? I know that the hospital that I worked in, we had probes that we used in one particular department. Cardiology, once a month, had one consultant that wanted to borrow one. So we used to lend it to him. He then had a friend that was in another department, so he'd share his clinic with him, so half the time it would go to his friend as well. So we had no record of who it was used on. And if there'd been a problem, how would we know? How would we know how to recall those patients or even trace them? How would we know if we had an infection risk? How do you know if somebody's borrowed your probe that it's been cleaned properly? Do you pass the SOP that you've written, you've got signed off with in conjunction with infection prevention? You've got that tied up. You know that your process is correct. When you let somebody else borrow it, do you give your SOP? Do you make sure they sign it so you've got a record that that's being done? How do you identify the risk of that? Do you put it on the risk register? What is the risk of that? And how do you bring all this information together? How do you record it? Have you got an electronic system? Is it a paper system? Is it a combination of both? If you've lent it to somebody, do paper records come back that you have to then put on your computer? How's it all linked together? When you're talking about cleaning a probe, there's two processes here. There's a cleaning and there's a disinfection. If you don't have it clean, you cannot disinfect it. If it's got gel on it, if it's got bodily fluids on it, if it's got tea splashes on it, you cannot disinfect it. Whatever's covering that probe will affect the disinfection of it, and the area under that bit of contamination will not be clean. So when you're thinking about the cleaning is probably one of the most important parts. You're looking at Sinner's Circle. Now this was developed in '59, donkey's years ago. But there's 4 aspects to Sinner's Circle. The mechanical action, so how you physically clean that probe, the pressure you put on it. So if you squeeze it really hard with your detergent wipe or whatever you're going to use, everybody will do it slightly different. What's the contact time for the detergent wipe? Is it a minute? Is it 30 seconds? How do you do it? Does everybody know you go from clean to dirty, or are some people doing it the other way around? Look at the detergent you're using. What do the IFUs from the manufacturer of the probe say you can use? What do the IFUs from the manufacturer of the detergent say you can use it on? You know, you might have 2 different detergent wipes. One has a minute contact time, one has a 30-second contact time. Unless you read it, you don't actually know. So you need to look at that. Compatibility, effectiveness. You know, what is on that probe that you need to clean off? You've got gel, you've got bodily fluids, possibly. What are you trying to clean off? The gel will be a different type of contamination to bodily fluids. Is the detergent wipe that you're using effective at getting both off? Does the detergent wipe have a temperature range? You know, if you're using it in a room, in a porta cabin gets extremely hot in the summer and pretty cold in the winter. What's the temperature range? Does that affect the contact time? You know, most wipes are sort of, you know, they're used between sort of 18 and 25. In the winter, the first patient of the day, it might be colder than that. Does that mean that that wipe's ineffective? In the summer, it gets very hot. Does it mean the evaporation of that? So the concentration of the detergent is higher. Does it have effect? Does it affect how long it has to have the contact time with the probe? These are all questions that should be resolved within your SOP and written out. What happens when what you're doing with that ultrasound probe changes? So, if we think about sort of intact skin, you don't need high-level disinfection for intact skin. But if you're going over eczema or broken skin or somebody's had an operation and it's not fully healed, you might need to change your method of disinfection. And think about sort of low level to high level. Does your SOP reflect that? As I said, the toolkit that Nanosonics have developed, their expert group have developed, actually gives you a flow chart of what happens if you change from low level to high level. It's free, use it. You don't have to pay for it. You can adapt it to what you're doing. You don't need to stick to it rigidly. You can adapt it, put your own scopes in. If you've loaned your scope out, how do you know that the procedure that they've done hasn't changed? How do you know that the skin isn't broken? The patient has got a rash. They've reacted to something. You know, a detergent or something at home they've reacted to and they've got a rash. How do you know there's no bodily fluid coming out of that rash? It might be slightly damp, you know. You don't know the scope that you've lent out is coming back to you. You don't know what method of disinfection to use, whether to use low level or high level disinfection. There should be a risk assessment to mitigate that. So you're talking about mitigating the risks. You go from one flow chart to another flow chart. It changes from non-critical to a critical device. If you've got bodily fluids on it, it becomes a critical device, and you need a different method of disinfection. Talking about sheathing. When you talk to a sonographer, most sonographers say it's very rare for a sheath to break. It might be, but how do you check it? How do you check that a sheath hasn't broken? You wouldn't see, if you've got a micro tear, you wouldn't see that unless you filled it up with water afterwards. You haven't got time to do that. You're in a busy clinic, you're going patient after patient. You haven't got time to fill each sort of sheath up and check to see if there's any water leaking. You probably haven't even got a sink in there to fill it up with. So what is the risk? An obvious break is you're going to know about. You know, it comes apart, you push it through the end of the sheath, you know about that. But the micro tears you do not know about. So when you're talking about disinfection, you clean the scope, what is the risk to the patient? What is the risk of viruses or bacteria still being on that if it's had a micro tear? And you wouldn't be aware of that. No one would be aware of it. So do you say that anything in a high-risk procedure gets high-level disinfected? It depends on your risk assessment and your hospital policy and what your SOP says. Sorry, just pushing it back to you now. Oh, that's it. So, who checks your probe? Who's responsible for it? Is it the operator? Has the operator had training? Is it the user? Now, when you look, the user within HTMO 101 Part A is the person that is legally responsible for putting something into use, to say that it's fit for use. So when you're reading SOPs and it says the user will check, actually you are then saying that you are legally responsible for that. If you say the operator, then you've got the responsibility of the operator, and it's getting the terminology right according to the HTMs. I'm sure everybody's aware of the HTMs and that, and it's just looking, I think it's on page 26 of HTMO 101 that it tells you the definition of what all the names and initials stand for. It could be the poor healthcare assistant. The sonographer might do all the scanning. The poor healthcare assistant might be there cleaning everything. Are they responsible for it? Who is ultimately responsible for looking at the probe and saying this has been cleaned and it has been disinfected to the correct level to be used on a patient? Okay. What training's taken place? Have you recorded that training? If it's not recorded, we know in the NHS, if it's not recorded, it hasn't happened. So have you had your training? Has it been one person's been trained and then they've told everybody else? Or is it everybody's had training? And how often do you have that training? Do you have it once a year, once every 3 years, once every 5 years, once? Think of Chinese whispers, how that starts. Things change. I went to a hospital a while ago and 2 ultrasound rooms. One, the probe was upright, the other one, it was hanging down. Same hospital, next door to each other. The people have been trained in different ways. Is there a dedicated area for the cleaning, or are you putting potentially your patients or staff at risk by manually cleaning it in the room where the procedure is? How are you cleaning it? Are you, we've talked about COVID, aerosols and all that sort of thing. Are you going to generate them while you're cleaning the probe? What PPE are you wearing? How are you keeping the staff safe? If you're cleaning it in the room, are you keeping the patient safe if the patient's there? It's quite a thing to sort of think about. So when we think, no one's ever got an infection from a probe. Actually, there was an MDA alert out. Somebody died from hepatitis B. Direct result from the probe. It was a TOE probe. It had a hole in it. Hepatitis got into the probe and was subsequently given to subsequent patients. The staff had no idea that the scope was infected. So it wasn't leak rate tested. You can't test most probes for leak rate. You don't know whether they've got a hole in them. This one, you could use a scope vault, which would pressurise it. The probe was manually cleaned. There was no record of contact times. So no one knew, even though they'd got a system in place, there wasn't a record of how long it had been cleaned for. There was training, everybody had been trained, but it was a few years ago and there was no refresher training. The training was done on generic scopes, it wasn't done on individual scopes. So the TOE probe, they'd got 2 different manufacturers, training had taken place on one manufacturer, not on the other manufacturer. There was no dedicated decon area, it was shoved in the corner of the room and they did their decon there. So they were trying to get it, pressure of work, to get it through. They had good traceability, so they were able to trace the subsequent patients, which is why the MDA issued the alert, because they knew that it had come from that probe and it had killed somebody. So, when it wants to move on, there we are. Scotland have done a study, which is brilliant, because I think, as far as I'm aware, it's the only study that's ever been done, and really we should do more of these. Do patients get infections from procedures? Yes, they do. Do they come back to the hospital? No, they don't. They assume that their infection was from something else. It's nothing to do with the procedure they had at the hospital, because it will develop days later, maybe a week, maybe 10 days. So they are not aware that the procedure they had has caused them an infection. So they go to their GP. It is never linked. This is where the NHS isn't good at sharing information. It's not linked up. They don't think, oh, they had a procedure 10 days ago, it might be linked to that, we better report it to the hospital. It's taken in isolation. A really good study, that. But it's getting old. It is now, nearly 12 years old, some of that data. And it was historical data looking back. So it does need to be repeated. We need to look and see if we are still giving our patients problems. There was a more recent incident in Cairns in France where a liver resection was taking place and subsequent patients got infections. It was due to inappropriate cleaning of the probe, but it was due to them being busy, a lot of turnover, staff not being trained, the ultrasound probe actually having a problem with it, but no one recognising that there was a problem. So they closed the theatre, they swabbed everything, they didn't find a problem. When they came to look at it, they discovered that when they immersed the probe into water, they got contamination and they were able to get growth from it. And one of the little seals had gone, and contamination had gone down through there. So the learning outcomes was the probe wasn't sheathed, should have been, but the clinician didn't want it sheathed. High level activity, they were busy. They were really busy. They weren't thinking they could get an infection from a probe. And the lack of training. They didn't recognise that this could be a problem to the patient. Okay. So you need to be aware of the risk. Sort of dirty to clean route, Spalding classification. Low risk, medium risk, high risk. Non-critical devices, non-critical devices. Low-level disinfection, high-level disinfection. Know what your risk is with your scope and know that it can change. You can go into a procedure that you don't imagine it will be high risk, and then suddenly the patient has something that you need to deal with. You need that accurate traceability. What did you use? When did you use it? What was your time frame? Who did it? Lot numbers. All this needs to be recorded. The staff, prove that they've had training. If you can't prove they've had training, somebody in court will say they haven't had any training. You've got nothing to go on. Talking about the toolkit. Now, as I said, this is free. Just go to their website. You can download it. It's quite a good sort of toolkit. There's 4 tools. The first one will tell you where to find your probes. Then you go on how to clean them, the risk assessment, and then the policy. So there's draft things in there that you can just change the name, change it to your hospital, change the procedure just slightly. The majority of it is done for you. So the first part, say it's location of it, and it talks about the asset register. Get your list from the asset register, record it. You will never find all your probes. Believe me, I don't reckon any hospital knows where all its probes are. You know, purchasing, the gel, the sheaths, they will help you. Just going around doing audits, just looking in cupboards. Oh, there's an ultrasound probe there. Looking at consultants that come in because they bring their own ultrasound probes. They move from hospital to hospital bringing them. Don't believe me? They do. So you can see this is broken into 3 parts. It's self-explanatory when you go onto the website and look at it. Again, the second tool, this is the sort of flow diagram. If things change, how to swap over. It's a flow diagram. It's easy to follow. Adapt it to your own facility. And you've got the risk matrix, exactly the same as most hospitals use, except I think most hospitals use sort of 1 to 5, and 25 is, you know, you're always being told to reduce the risk. You can't go above 16 because then you get a problem. You then get into the pressured area. Again, it's how to look at the risk, and you know, if you're going to follow medical devices, there's a standard 14971, which is the standard for risk assessment for medical devices. You can look at that. That's reflected in this method of risk assessment. Also, it's the majority of ways that the hospitals will do risk assessments. So you've got what the risk is, the potential harm, how likely it is, and your mitigation, what you do to reduce that risk. And then the outcome at the end. And, you know, hospitals like it to be red at the beginning and green at the end, so that there's no worry for them. They don't have to worry. So these are 2 examples that I had. So the first one I was asked to investigate was finance questioned a high repair bill of a probe. And they were saying, why are we always sending this probe for repair? Well, the department was really well organised. They had SOPs, they had everything, they did audits. Everything was absolutely fine. The only thing they didn't have was they didn't have the IFUs from the manufacturer. But they'd had the probe donkey's years, so they knew that they were right. When we'd sent off for the IFUs, we found that the chemical they were using wasn't compatible with the device, and that was what was causing the problems. And it was the fact that the hospital as a whole had been told to change their wipes to a cheaper wipe, and everybody had assumed it was the same chemical composition. It wasn't, and that's what caused the problem. So we did this risk assessment, changed the chemical back, and the problem seemed to alleviate itself. Okay. Oh, and have to, hang on. That's it. This one was bladder scanning, and it was a new nurse that was doing the patients that she'd watched. She's doing it for the second time. One of the patients said, "Oh, I had to be put on antibiotics last time after I had it. Would I have got it from here?" So she came back and questioned it, and I was asked to investigate it. And it was there an SOP? There was. It was in the manager's office on the shelf. No one knew where it was. What was the probe cleaned with? Well, whatever wipes were there, because it was a continence clinic. There was no risk to the patient. It's who cleaned the probe? No one knew who cleaned the probe. It was assumed that it was Nurse X because she did most of the scanning, but actually she swapped to have a tea break in the middle. So it was around tea break time. We assumed it was this nurse, but it was all done on assumptions. So we had to look at the SOP, we had to look back and say, right, what happens when you're scanning intact skin and then you get a patient that's non-intact skin? Do you change that method of disinfection? Yes, you do. That wasn't happening. So there was quite a rework within the department. A simple thing. Continence clinics, they scan hundreds of people every day, but it just wasn't recorded accurately of who'd done it and what had happened. Right, speed through this. So this is Toolkit 4, which is developing a policy and SOPs. There are examples of them within online, so you can just download them and use them. That's it. So what I would say is don't assume, never assume anything, read the small print and use your risk register. Because if you use your risk register properly, you will identify risks, and if the hospital try to change something, they need to be aware that if you change A, B might happen. Okay? Thank you very much.